case study, current concepts and techniques of diagnosis, because there are some changes. And this is treatment. The case study is kind of a mixture of both. It's JOGO treatment, which was important, and a mixture of PT, standard PT for MS. And I'm not, how do I make this advance? Ha ha. I don't know. How do I get the next slide here? Ah, down at the bottom, right? Okay, features and definitions. Sorry, this is a new setup.
You could also press the, I think, the enter key or the button, the low arrow. Yeah,
I'll try the enter then. So features and definitions, you know, we all learned about MS in school, but we get a little rusty, I think, or at least I do. I just want to change. There we go. So MS is a neuroinflammatory disease that affects myelin, and myelin wraps around the nerve fibers, the axons. In MS, there's damage to the nerve cell body, which is gray matter, the brain, spinal cord, and optic nerve. White matter is degraded in an inflammatory reaction. So you're talking about the entire neurologic system here. Immune cells mistakenly attack myelin. MS refers to distinctive areas of scar tissue, and this has diagnostic relevance, that you may have heard of as plaques, and they're areas of scar tissue that are visible in the white matter. And let's see, no, that didn't work. So the characteristics of the disease, the etiology is unknown. Pathogenesis is grouped in immune factors, environmental factors, and genetic association, but it's not a directly inherited disease. Earliest known neurologic disease, it's the earliest known neurologic disease, which this was new to me, described by Charcot in 1868. So it's been around a long time. The onset is mostly young adults, age 20 to 40 years, but it can occur at any age. And 10% of cases occur before age of 18. Again, incidence is greater in females, and it's having a biological relative with MS, you have a 2 to 4% risk of developing MS. So it's not a direct inheritance. Some of the characteristics, there's in 1 in 1,000 in populations of European ancestry. There's lower prevalence in East Asian and African descent. Increased incidence in northern latitudes of Europe and North America, estimates of 200 to 400,000 in the United States. It's the most common disabling neurologic disease of young adults. And there is a normal life expectancy. Some of the symptoms, some have a mild course with little to no disability. Most have short periods of symptoms followed by long periods of quiescence. No cures, no prevention. As disease progresses, there's cerebral atrophy at a higher rate than would occur with normal aging. And the particularly noted is the cerebral cortex just diminishes. Symptoms depend on the severity of inflammation, the extent of plaque formation, which primarily appears in the brainstem, cerebellum, so you have balance problems, spinal cord, optic nerve, white matter, and around the brain ventricles. And so there's types of MS. They've been characterized by relapsing remitting, which is the most common, and it occurs with an exacerbation can happen, and then a remission can be weeks, months, of years between the attacks. And they usually return to the previous level of disability. So if they started out, they couldn't, or if they couldn't walk, they're not going to be able to walk afterwards. But during either, whatever their problems were before, they'll return back to that level. Secondary progressive MS develops gradually with steady symptoms and deterioration. Primary progressive MS is less common, progressively worsening symptoms and acute relapses. And then there are variants to all of these that affect the progression of the disease. So there's a couple of different named variants that will either accelerate, that usually accelerate the symptoms.
So they have the symptoms are like here normally, then they have an exacerbation, they go down. But they don't always go back up to this top level again. They end up lower and then lower. Is that how it works?
Well, yes, they go, but what it means is they're not going to, in that, in the period of exacerbation, once the exacerbation is over, they're not going to, go back to a high level. They're going to keep going back to the.
So they start here, but they have a
level they
problem, then they
were
go to here,
at.
then they go to here. It doesn't ever go back up again.
Yeah. There's early symptoms occur with vision problems, muscle weakness, tingling, numbness, or pain in the arms, legs, trunk, face. There's clumsiness, bladder control problems, and dizziness that's prolonged. In the later symptoms, there's mental or physical fatigue, mood changes. Lability can be up or down, inability to concentrate or multitask, difficulty making decisions, planning or prioritizing. And this one is moving the neck in any plane of motion will cause what's called a Hermite sign, which is like a sharp spike of electricity down the spine. Difficulty with coordination and balance, and intolerance to heat is.
So the Hermes sign could be a good diagnostic.
Pardon?
So the Hermes sign can be a good diagnostic to differentiate from other neurological stuff.
Well, I think it's only one possible symptom, so you need a cluster of symptoms and the plaques to be diagnosed. Yeah,
fair enough.
The causes and theories of the causes, the cause is not known. We don't know, they don't know why the immune system suddenly attacks normal tissue, but there are hypotheses based on knowledge, all right? So one hypothesis is that the body's fighting an infectious agent that mimics the components of the brain, destroying brain cells that are unhealthy, the immune system's mistakenly identifying brain cells as foreign, variations in the genetic code causing vulnerabilities, but it's not inherited. So similar to an autoimmune disease. And then there's a theory of a break in the blood-brain barrier, which is a barrier that protects the brain from the immune system, that exposes the brain to the immune system. This was interesting, Epstein-Barr virus is linked to MS, which I never knew. People with high levels of vitamin D are less likely to develop MS, which may be why some of the warmer climate areas have a lower incidence. People who smoke are more likely to develop brain lesions and shrinkage, also interesting. I thought the thalamic tissue volume loss is found in all subtypes of MS. And the thalamus relays sensory information for cortical activation. So quite important. It's diagnosed through MRI, which is, usually they do the spinal cord, the brainstem, and look for the plaques. Lumbar puncture, they look for proteins or inflammatory cells. And there's a test called the evoked potential test, which measures how quickly the nervous system will respond to stimuli. So the treatment, the medical treatment is corticosteroid infusion, plasma exchange, beta interferon drugs, then this other drug, this is a kind of a newer drug that they're very excited about. It's called natalizumab. It prevents immune system cells from entering the brain, given no other course of, it's only given to patients who don't tolerate anything else, because I guess it's got a lot of downsides. Many other drugs by mouth or infusion or injection, there's like 2 pages of drugs if you look on the MS Foundation site. Treatment, physical activity, comprehensive programs are necessary. Things like yoga, stretching, strengthening, may use assistive devices for gait, general, and teach conservation techniques, because there's definitely a fatigue factor, especially in the later stages. There's psychological counseling, and then they list alternative therapies, acupuncture, aromatherapy, yoga, and biofeedback, and herbal supplements. They think that, or the neuroplasticity would not only be a factor in biofeedback, but also in the exercise programs and rehab to improve function, may be forming new pathways. That's the hope. The NIH has a division that's doing a lot of research on MS, looking into biomarkers to diagnose MS, genetics and environmental risk factors, the role of the gut microbiome, mechanisms that underlie gender differences in incidence and presentation, because it is a higher rate in women, MS risk factors and disease in African Americans and Hispanics. Obviously, again, from warmer climates, is it the vitamin D factor or something else? Role of immune system, the role of crosstalk of various cell types in CNS, basic function of myelination and demyelination, axonal degeneration, and strategies to overcome axonal myelin loss. In other words, why is our system attacking normal function, normal myelin? Stem cell research is again also very popular right now, and there's an NIH program called Beat MS to reset the immune system. And I attended a webinar, and the researcher was very excited about the possibility of stem cells as a way to cure MS. Genetic research, better MRI imaging techniques, they feel is necessary. New techniques need to be validated. Genetic and environmental risk factors need to be studied, and studies to develop therapies. So I list these all because there's so much going on, research going on MS. And when you look at it, this was a disease that was described in 1868. And so many other diseases, even many cancers, have been cured. Why hasn't this? It's really a problem. So the case study is, I had a female patient. Her date of birth was May 21st, 76. She was diagnosed in 2017. She described her symptoms when I first saw her as pain and gait changes on the left side of her body. Her symptoms, she complained of in the lower extremity of 5 out of 10. When she described pain, she talked about it more as tightness and inability in controlling the leg and gait. And her best was 4 out of 10 on the lower extremity. The upper extremity was 3 out of 10. She felt her activities were limited by 30%. She states she trips and thinks her foot does not clear, and it didn't. Her ADL, she was independent, slight difficulty with some work and social interference. She trained as a lawyer, but I think she now does little projects and writes for various projects. She was very unclear about that. So I won't say exactly what she does, but obviously she does attend conferences she had talked about. She presents at different things. So she's in Cambridge, so she's in the academic world. Her goals were symptom reduction, so less stiffness, easier movement, and gait, easier movement, particularly with gait. And currently she was doing MS workouts, 2 classes, working with bands and weights, aerobic exercises, and a program programs through the MS Foundation, as well as attending support groups. So our initial evaluation, she had an MSHQ of 40 out of 56. Her Berg's was 48 out of 56, which is very good. Her posture was, she had flat feet, she has increased joint flexibility generally. That was just her structure. She had good standing posture. Strength, her upper extremities. I saw her in person for this, so this is why I had more specific strength values. On her right upper extremity was generally 5 out of 5. The left was 4 out of 5. Hip abduction was 3+ over 3, right over left. Quadriceps 4+ over 4, right over left. Hamstrings 4 over 4, and her dorsiflexors were 3 over 3. Her gait, she had uneven arm swing, decreased dorsiflexion, left greater than right, and that's where she'd catch her toe. Left pelvic drop on right stance, which is another reason she'd catch her toe. Spastic circumduction of the foot on swing. So when she picked her foot up, she would go into a little bit of a circumducted. It was very kind of bizarre, but the foot was constantly kind of wavering, or you could see the spasticity just kind of going through, not in a smooth way. She could do stairs only one step at a time using the handrail. She was independent in self-care, she claimed, and housework, although she had help. Her 5 times sit to stand was normal. So our goals were to decrease the stiffness, improve her gait. So she wanted to be able to walk 1 mile with her husband, like in the evenings. That was one of their activities. Use of JOGO biofeedback, increased dorsiflexion +5 degrees on the left at least, and increase hip strength 1/2 grade. So her PT and JOGO treatment summary was generally, I instructed her in strengthening exercises. Now, she did a lot of exercise programs that she described to me through the MS Foundation. And so I just supplemented that with the specific strengthening that she needed. Hips and knees, upper extremity strengthening, and energy conservation. We did some stretching of the calf and eccentric work of the plantar flexors, and upper extremity stretching. We worked on her balance, even though her balance was pretty good. It's always good to work on balance, which also is a functional way to pull in the hip muscles and core. Posture at the computer, we like to correct that because she did use the computer quite a bit, and that would affect her, particularly in the upper extremities. On JOGO, we did tension recognition and discrimination for the left dorsiflexors in various degrees of freedom. Cautioned her against fatigue in doing her JOGO because, you know, she would tend to, she's a kind of a close to a type A, so she would try to do too much. Deep breathing for her let goes, visualization, functional use we progressed to functional use of the unit for gait. So put it on and have her walk, and hip abduction on the unit was the final group that we worked on. All exercises were gradually progressed. The patient kept a spreadsheet for JOGO practice and was diligent in doing it. Patient stated she could feel a difference after using JOGO. She felt more activation in her muscles, she said. And that was almost from the beginning, right after she started using it. She had low baselines and could reach targeted goals on the unit. So she was a good user. And upon discharge, she had about 10 to 12 visits. I was trying to count them up, but I lost track. Her MSK HQ was 45 out of 56, which was one of our goals for her to at least increase by 5. She could take 8,000 steps a day. Her pain levels were 0 to 2 and felt tightness only. Her gait was within normal. She wasn't catching her toe. Her pelvic drop had decreased. She had just a slight drop, but it wasn't anything that was consequential. She could walk stairs foot over foot using one handrail just for balance. She claimed her stamina was excellent. Her ankle range of motion increased 5 degrees, and the patient will continue her exercises and all her MS classes, which she loved. And these were some of my references. So that's it.
Wow, great job.
Good job, Sheryl.
Brilliant,
Sheryl,
brilliant, Sheryl. Amazing.
yeah.
What
Sheryl,
different
where
cause-
did you do? What did you do for the pelvic drop? Like,